Black women currently are 3 times more likely to die during pregnancy and childbirth than our white counterparts. And you have to wonder, well, what is that? They've done a lot of research, and there's a lot of information on ACOG, so American College of Obstetrics and Gynecology, that shows that some people would automatically think maybe we are at a higher disposition for, I don't know, conditions like diabetes or hypertensive disorders, when actually the reasons are systemic racism.
Right.
So just to be very clear, that is a known risk factor now for conditions like preeclampsia, gestational diabetes, and just for kind of being at a higher risk purely because you are Black, and it's nothing to do with us being Black,
Right.
nothing to do with us at all. It's to do with the system and how it perceives Black women, and that we're therefore at a greater risk of complications not being listened to and things just going wrong purely because we're Black.
A lot of times when I'm talking to physicians or any healthcare visionaries, their mission-based company typically stems from a very powerful story from themselves, right? And I know that during 36 weeks in your pregnancy, you were actually diagnosed with preeclampsia, and you were not informed until 8 days later, and you actually had your husband go take a look at the lab results. So take us back to that moment in time and really go through that journey.
Yeah, I think just going back at that moment in time, I was a physician. I was working in the ER at the time. So I was a junior physician, but, working in and amongst the system with my colleagues. And I really trusted and believed that I would get the very best care during my pregnancy. And this was my very first pregnancy. I was technically considered low risk and had basically gone through the whole prenatal care journey as you would expect. But I was noticing a lot of things were being missed or not followed up correctly, and I was having to question things for myself, which again, it was okay. I started to feel a little uneasy, but I still believe that I was technically low risk and healthy. It was only towards the end, so sort of as you mentioned, around a 36-week appointment, I actually had a urine sample sent to the lab and didn't hear back. Usually that means it's normal,
Mm-hmm.
but didn't hear back, but was getting a little concerned that it'd been so long. And I was also having some other symptoms. Reduced fetal movements was one of the main reasons why I took myself in. And then I went in, and as you mentioned, my husband was sort of checking, well, there was this urine sample. It wasn't reported back to us what the results were. And it's only then that they did go and check and said, actually, it looks like you have preeclampsia. And at this point, I was quite surprised because, again, there had been no, outreach to me. There'd been no one calling, there'd been no one messaging or anything like that. And if we hadn't been there, I wouldn't have known. And that led to the spiral of events around the labor and the birth. And it was decided to induce me, which didn't go very well. I just had a hyperstimulation reaction, which is not that common, but it happened, unfortunately. But the issues really were more around the lack of adequate staffing, the lack of time, the lack of ability to really just spend time with patients and listen. And I was on the end of that, which meant I didn't really get the care that I should have.
Right.
And it really just ended up in a crash cesarean section because my son's heart rate had dropped so significantly that we basically had to run. And, that in itself wasn't necessarily a shock or a surprise because these things can happen. But what was a shock was that actually many of the issues could have been prevented had we
Mm-hmm.
just had good enough care at a certain point. And yeah, that was a real eye opener. I think when you are a physician, when you're a health professional working in your own systems, you really do believe that everything will be fine. And
Right.
sometimes you think you might get better care, which is not,
Right.
necessarily right.
Right.
But in my case, it just did not go that way. And, there were many reasons that we later found out caused this. But yeah, it was a real eye opener and a real surprise for me.
For sure. And like you mentioned, the fact that you were a physician, unfortunately, you would expect, they would pay a little bit more attention, but you experience with what a lot of women are experiencing as well. What was it about your experience that caused you to second guess your lab results? And is your husband in the healthcare industry?
No, I think luckily for me, when you're the patient and you're also a healthcare professional, whether you're a physician or a nurse or anything, sometimes it's not quite the same as being at work, in work mode, and looking up other people. You're thinking so many different things and you're second guessing almost everything because you're wondering if it's because you're a health professional that you're
Hmm.
questioning things, or are you actually correct in what you're thinking? So I think there was a lot of moments that made me wonder. I'm very petite, 5'1", and my bump always appeared quite small. But every time they would measure my bump, it was always considered average, which I thought was actually very unlikely given my size, given my background, my family and everything. And marking it on our growth charts is what we used. It always seemed to be consistently average, but it didn't quite match up to my expectations because when I would measure myself at home, I was small. So that in itself was another thing that kind of had me on edge. I think I was expecting a small baby. What ended up happening was that only when he was born, at actually 37 plus 5 days, did we find out my son was only 4 pounds 13 and
Wow.
had actually stopped growing from around about 28 to 31 weeks. We don't know because, as I
Mhm.
said, they were just marking things on the chart as average. So there was a lot of small kind of hints and clues that led up to quite a bad outcome, honestly. I think I was lucky that my husband would do the questioning that I might otherwise forget to ask or kind of just believe the answers that I was given. And
Mhm.
he just remembered the urine sample at that time, which was great for me
Mhm.
because, like I said, I think if we hadn't have mentioned it at that moment, we probably wouldn't have seen anyone for another week. Since we now know my son was not growing, the placenta wasn't working correctly, we don't know what would have happened if we had waited another week. So yeah, it is good to have someone that can advocate for you and with you and can ask the questions that you may not know to ask in that moment and to kind of just help you out where you're in a vulnerable position as a pregnant person.
Absolutely, absolutely. So after the complications, you kind of embarked on a journey to really figure out what was going on and why this happened to you specifically. How long was it before you actually started to think about creating a company to really solve this problem?
Yeah, it was actually 4 years. So I think this was one of the tricky things that came out of this experience for me. I wasn't sure whether I would go back to work and continue an ONG, obstetrics and gynecology residency. But I did. I thought, you know what? I probably am now in a position to be able to have a better impact on patients' lives, having gone through what I've gone through. So I did my residency the entire time. Sister, who was out here in San Francisco, had just gone through Y Combinator and started her own company, encouraged me to investigate what actually went wrong in my care. And it was a little unusual. I don't think many of us do that. You feel like you're kind of against the system that you work for and,
Right.
that you support, but it did take 4 years to fully get the results of this investigation. And in that time, I think I was picking up on a lot more issues that were affecting the wider community. I felt like I was trying to advocate for patients one by one by one by one by one.
Hmm.
And it was becoming quite evident that perhaps we as physicians are not necessarily taught everything kind of in the correct ways. And perhaps we do have bias and we do have some elements of systemic racism in the way that we're taught. It was becoming a little difficult. So 4 years later, we finally get this report. Essentially, the hospital were quite upfront and admitted negligence way straight off the bat, honestly. But we did have to go through the whole process. And then it was after the report had come out that I realized there was actually several more issues that I wasn't even aware of.
Hmm.
And myself and my sister were sort of in a position where we were like, with this information, now what?
Right.
What do we do with this?
So, for anyone who's interested in really kind of diving into really research and, really figuring out where the issues are in the system, how would one go about creating or starting a study like this? Did you do it at a local hospital? What were you looking for? And then what were the actual findings?
Yeah, so in my case, because I was the patient, I could simply request that I have access to my own medical records. I take that and have a look at it for myself. But I also had a meeting with many members of the maternity care team at that local hospital of mine. And it was in that very first meeting when, honestly, it was only 4 to 6 months after my delivery that we all sat down and could see the issues as you flick through the medical record and find what actually went wrong. So it was a team effort. It wasn't just me against them. They were genuinely looking for the issues, found some things that I mentioned that I hadn't found. And we're quite open and honest about the whole process. So it was about making that first communication step. So I reported to the local hospital, to the maternity department, what I thought, and they arranged a meeting for me and followed up with their
Oh,
findings. So it is something that I think a lot of people don't know that you can do. It doesn't
right,
always have to be like a us against them mentality. I think the
right.
goal here was to come up with solutions to basically make sure, somewhat try to make sure that it didn't happen again to the next person. And that was why I decided to investigate anyway. It was just a case of, well, literally tomorrow, another woman in the bed next to me could go through the exact same thing and no one would know. And in fact, what made it more interesting to me was that she would probably think that it was her fault. You know how we are sometimes, we will put the
Yeah,
blame on ourselves, and
yeah.
actually it's nothing to do with us. Sometimes when you're the patient, you're just the patient. There's not much more you can do. And so the real drive was just sitting down and finding solutions. So they were quite helpful, came up with lots of recommendations and talking about, taking the teams back into training, editing their policies and their procedures, having a look at things like what it means to have a hyperstimulation reaction, what they can look out for. And so yeah, you can definitely do that if you're the patient. If you're a provider, we often do things like quality improvement projects anyway, where we'd
Hmm.
look at a larger data set of what could be going on in our units and departments. I did one around readmission postpartum for infection. So you can absolutely do that. I think many of us are familiar with the processes there, but with that, you can start to pick out perhaps trends and ultimately recommendations as to how to improve things long term. So, yeah, I mean, I would highly encourage anyone in a position to do research, quality improvement, audits in their departments to, of course, do that. And if you're a patient who thinks that maybe something could have gone better, you
Hmm.
don't have to be afraid to just ask and see what can come of it. It doesn't necessarily have to be a lengthy battle or anything like that. It could
Right.
be a collaborative discussion.
Perfect. And before I want to kind of just go into maybe the top three things that you noticed went wrong in your
Oh, sure.
particular situation, for the average individual, if they feel like something did go wrong or they had a complication in their experience, who specifically can they reach out to at the hospital? And then, what team are they going to be able to partner with to actually get an investigated started?
Yeah. It goes down to who's in charge of that particular unit. So you
Okay.
might have an obstetrician who is head of labor and delivery. You may have a nurse manager. You can absolutely find that information on the hospital's website. There's no hiding it. You can call up and just ask for that person's email address or contact information. Oftentimes what I've seen is that you actually receive a leaflet. After your care,
Yeah.
you'll ask for feedback sometimes, and you will receive a leaflet that has or complaints
Right.
will be on there. In my case, we had a patient advice liaison system, which is, we called it PALS. And there was an email address and a phone number. And I wrote maybe 4 or 5 pages in a document and sent it to the email address, almost like a letter. And that kind of started it. So there is a very transparent process for complaints in most hospitals, honestly. And I would just start there. It would be ideal to speak to the people that know. So in those labor and delivery units or in the maternity care space, and just let them follow their procedures. They all have procedures. So you don't need to necessarily go digging, just have to contact the right person.
Perfect. And are there any external organizations that advocate on your behalf for complications? So should you not want to, interact directly with the hospital?
That's a great question. And I can't say that I know of any.
Okay.
I would be interested to hear because I could only imagine that it is very, I mean, it is very difficult to sometimes fight for yourself. And I'm sure there are, but it's not something that I've come across just yet.
Sounds good. So, based on your experience, what were kind of the top three findings that you noticed in your case and that are very common with other women as well?
I think number one, and I know there's many women out there that would agree, is just not being listened to. I think that in itself is one of the biggest causes of complications. Not necessarily the medical issues around what's going on, not necessarily labs, not necessarily anything. It's really just not being listened to. So in my case, that started in the prenatal period. So not really listening to when I would say, "Are you sure I'm measuring correctly?" It just seems a little bit off to me. But also during my induction process, where I was reporting several worrying symptoms, bleeding, pain, vomiting, unable to stand up, unable to sit down, when I was actually contracting 9 in 10 minutes, which is
Mm,
highly abnormal, but was being told that it's your first baby. You're not in labor. Just wait. Nothing started yet. Like you couldn't possibly be in labor. We just induced you with the medication an hour ago.
Mm-hmm.
So when you look, it's very simple. It's very straightforward. It's clearly a reaction, needed to be taken out, probably would have been fine, and we could have carried on and even gone for a planned cesarean section, sure. But in my case, I was not listened to. So I was left in this reactive state for 6 hours the entire time. My son's heart rate was dipping, and I didn't even have monitoring even at that point. So I think it's a case of, if you're in a position to care for someone, just listen. That
Mm-hmm.
was the biggest thing in my case. The second was follow up. So a lot of the times, you're doing lab tests on hundreds of people in one day. You're looking for a result. It can become very tedious and very difficult to keep up. But
Right.
having systems in place that stop things from kind of falling through the cracks is super important. That would have helped me with just diagnosing that preeclampsia 8 days earlier, which would have had an impact, as we now know. And finally, it's things like following policies and being aware of those things as you're working. And sometimes it changes. So in my case, it's things like measuring correctly, making sure
Mm-hmm.
your training and technique is up to date, writing things down correctly. Documentation is sometimes not even done in these cases. And you
Mm-hmm.
go back to find out what happened and you don't know because nobody wrote it down.
Mm-hmm.
And then finally, things like knowing what to look out for and warning signs. So again, in my case, I don't think people were very aware of signs and symptoms of things going wrong, and kind of chalked it up to what's most likely happening. Oh, a young lady, black, complaining about being in pain.
Mm-hmm.
Well, I don't know, maybe she's just exaggerating. I felt that that was more the option that they had chosen than just exploring a little bit more about what I could have been feeling and what could have been going wrong, which we now know was going wrong. So yeah, those would be my top 3 lessons to learn, I think.
Yeah, for sure. Thank you for sharing that. And the fact that you were a physician, I'm so surprised that, you still didn't feel seen or heard. And I know when working with physicians, a lot of physicians want to leverage their expertise to really become consultants or liaisons to really provide that advice for, the average individual that doesn't even know what specifically to ask for.
Yeah.
In one of your blogs, it stated that the US has the highest mortality rate among high
Yeah.
income countries and that pregnancy can feel like a dangerous undertaking, especially for Black women. Can you share some of the data with us?
Yeah, so if you look at the charts and the graphs, the data around maternal mortality, so this is all about how many women die during pregnancy and immediately after childbirth in all countries across the world. Now, the US has the highest rate compared to high income countries. So that just means when you're looking at comparing us to places like the UK, Sweden, Germany, you know, areas where you have resources, that
Hmm.
means financial resources, you have trained staff, have amazing education, and people have access to healthcare. You would not expect these countries to have poor maternal mortality rates, but the
Right,
US has the highest amongst that group. So that just means, in a place where you have some of the world's best physicians, the world's best nurses, state-of-the-art technology, amazing hospitals, amazing facilities, why do we find that pregnant women are still dying at higher rates compared to other countries like the UK, Sweden, Germany?
right,
And I think what the research has shown is there's multiple reasons. Of course, the US is huge. There's geographical issues here. There's a lot of rural areas. But one of the reasons is that the Black maternal mortality rate is extremely high. So Black women currently are 3 times more likely to die during pregnancy and childbirth than our white counterparts. And you have to wonder, well, what is that? They've done a lot of research, and there's a lot of information on ACOG, so American College of Obstetrics and Gynecology, that shows that some people would automatically think maybe we are at a higher disposition for, I don't know, conditions like diabetes or hypertensive disorders, when actually the reasons are systemic racism.
right,
So just to be very clear, that is a known risk factor now for conditions like preeclampsia, gestational diabetes, and just for kind of being at a higher risk purely because you are Black, and it's nothing to do with us being Black,
right,
nothing to do with us at all. It's to do with the system and how it perceives Black women, and that we're therefore at a greater risk of complications, not being listened to, and things just going wrong purely because we're Black.
right.
And that's nothing to do with us genetically. It makes no difference, but it's something that is acknowledged today when it wasn't really acknowledged, 5, 10 years ago. And it's something that I believe people are actively working on. So that is still true. The US does still have the highest maternal mortality rate amongst high income countries, but there are lots of initiatives that are trying to bring that down. Obviously, working in the private sector and building a company around that is one thing, but there's a lot that's happening in policy and government, in the insurance space, with additional healthcare provider types, midwives and doulas rolling out across the country. There is a lot being done. So, I mean, it's a step, shall we say.
Right. Right. I mean, and spreading the awareness and having the system actually acknowledge that this is a problem so that, we can allow Black women to start advocating for themselves, and not necessarily relying on the hospital system to do it for them is definitely a great first step. Okay, perfect. So is it Astar? Esther? Asta.
Well, it's exactly how you would pronounce it, but my accent does kind of
Okay,
distort.
Aster.
Aster, yeah.
Astar. Okay, Astar. So, well, first, why did you call it Aster? Let's start. Why'd you name it that?
When we started the company, we had done a lot of research into what was out there, what types of solutions already exist, and found that typically in women's health, you're seeing a lot of feminine products. You're seeing a
Yeah,
lot of pink, purples, and the names are lovely. And, I mean, it was something that we thought, well, women's health is health, right?
yeah,
Why does it have to be pink? Why does it have to be purple? And why do the names need to appear feminine when actually what we're doing is delivering healthcare, full stop? Like, that's it. So we wanted to find a name that was reflective of that, that was neutral in the way that it felt, in the way that it would be to receive care via a platform named something like Aster. And then when we came to discover this name, we also noted that it was a symbol of fertility. It's a flower.
wow.
And in many countries, it's a symbol of fertility. So it just fit really nicely. And even in our product, we've kept things as neutral as possible. Our branding is all deep green,
Yes.
and doesn't really give you any clue as to who it might be for and what it might do. And I think that's been really positive for us because it's meant we started building a product that was inclusive from the very beginning, and that's just opened us up to a lot more opportunity, and it's meant that we've been able to welcome different types of people into our own community without feeling like their patients are going to receive communication from a pink flowery
Yeah,
platform with a baby's face on it or something like that. you know
absolutely. You're looking at the broader vision, right? Yeah, I love that, definitely. And so it is a EHR technology that enables women's health practices to manage, grow, and scale their practice. So
that's right.
I noticed that it is AI operated and AI is of
Yeah.
today. Was it always AI operated and what does it actually mean? And then talk to us about what your technology does.
Great. So I would say in the very beginning, all we wanted to do was build software for women's health providers. So we wanted to give them a platform that they could log into, they could use day to day to see their patients and care for them. And that was the basic foundation. So when it started, there was not very much AI in the product. It was things like a scheduling system. It was things like an ability to chart a patient interaction. So just somewhere to type your notes, really. But then as time went on and we were able to build out more of the product beyond just the basics, we started incorporating AI into every single piece. So today that looks like when you're uploading lab results, for example, you may have 100 different lab results in a single PDF document coming from a lab elsewhere. You could just click upload, and in Aster, the AI will read the results for you, type them out, put them in the right place, and tell you the interpretation based on that PDF. So that's one thing that was the very basic way that we started. It's kind of evolved since then. Right now, you can use Aster to log in, click on your patient's name, and read essentially a very short but very specific clinical summary about them, which includes all of their medical history, any visits that you've had with them, and what they're coming in for today, so that essentially you're not missing key information that you'd otherwise have to dig for.
Mhm.
All we're trying to do is provide providers with the information that they need to see the patient and give great care, which is otherwise usually disrupted by things like not having enough time, too much admin at the end of the day, having to write
Mhm.
things up, summarize them yourself, and looking through medical records, lab results, blood pressure results,
Yeah.
and having to dig and click and dig, so you actually don't ever find it. And you may just skip through some of these things so that you can get to see the next person so you can get home on time. So right now you're seeing almost all features in Aster with an AI element. And therefore it's kind of AI powered, but we use it in very clever and strategic ways so that it's really just feels like you have like an assistant sat next to you that's doing half of your work.
Right. That's wonderful. Kind of ties back into what you were speaking of in regards to the lab results, how, in the hospital they were going through all of these different labs and it becomes very tedious to really interpret and it's easy to kind of miss. But having, a system that would be able to kind of organize everything and then interpret it for you in just a click of a button really changes things. So I definitely see the development on the administrative side. But one of the things that stood out to me when I was doing further research was really trying to understand the ecosystem and everybody involved in the care of a woman, right? During pregnancy. And so we have the OBGYN, the midwives, the nurse practitioners, the doulas. I don't know what
Yeah,
MFM means, and the lactation consultants that typically operate ad hoc or independently. So does Aster help
right.
kind of merge the care so that we can kind of look at it from a holistic point of view?
That's a great point. So just to kind of go back, the MFMs are the maternal fetal medicine specialists,
Okay.
incredible people, incredible humans who have super specialized in taking care of pregnant women who have other conditions. So it could be gestational diabetes, it could be hypertension and things like that. Now, typically you are seeing these people individually. So you might just be seeing an MFM, an OBGYN. You might decide to have all of your care with a midwife and maybe have the OB oversight, or you might see a midwife outside the hospital, which is
Mm-hmm.
in the case of Aster, which is a lot of our users are midwives outside of the hospital who run and own birth centers or practices themselves and deliver care themselves independently. What we have though is a system that allows for everybody to communicate with each other. So it's collaborative in the sense that they can all use it successfully and collaborate with one another. That just means, for example, we have a labor and birth note. And this note is a kind of screen that you can pull up during labor. You can click on all of the milestones, all the events that are happening. You can type with a kind of the most minimal typing that you need, but you would still capture all the information. And then the next person can log in and do the very same thing on the very same sheet. And you end up with this very collaborative, real time documentation and log of what's actually happening with some of the interpretation that we spoke about before. So right now we do have some collaborative practices that have an OB, midwives, lactation consultants, doulas on there, which we find incredible. We have some practices that have all of those people plus pelvic floor PT, nutritionist, mental health therapist. We have so many people that are kind of working on the data side as well. So our platform, of course, captures tons of information and data, and we have practices that have a data specialist within them which can
Mm-hmm.
use Aster to pull out reports, look at trends, and analyze what could be going on with their populations and where could they make some changes. So it's super collaborative today. Longer term, the larger the customers that we get are, the
Mm-hmm.
more different types of providers that we're going to have on the platform. And we're set up for that now. But it definitely will be a long-term initiative to have multiple specialties on the platform, multiple providers,
Right.
and have everyone be able to access essentially the same information to keep it consistent and
Right.
standardized. You're not having gaps and holes in somebody's information and the care that they therefore receive.
Makes sense. So we can fully understand how it works. So if the OBGYN's office or group
Yes.
or whatever, the independent office has the system, if their patient is working, say, with a doula, does the
Yeah.
doula also have to have your technology or are they assigning them access to the technology that
Great.
is, yeah, go ahead.
There's a couple of ways that we work. Either the doula just happens to have Aster themselves and uses it for all of their clients.
Which would be
Great.
great.
In which case, fine. In other cases, if they're seeing a client at an OB's office and the client would like them to have access to their information, their records, be able to message them, be able to send them documents and forms, they would simply need to be invited by the practice. And we are, as we say, because we're so collaborative, we have ways in which you can do that really easily. And it may just be for that one client in which case after that, they may log out and then request an invite next time around. But if they're working with the practice regularly, we highly encourage that practice to just invite that person, let them have their own login, their own account,
Right.
let them have their own patient list and be able to filter through and use it regularly to see their clients. That way, information is kept in one place, which
Mm-hmm.
is really important and super useful because if I take a set of vitals on somebody and I find that maybe they're within normal limits, but it's a little bit higher than I would expect for this particular person. And then next week, the OB does the same and it's just a little bit higher still, then we become able to see a trend. It's not
Mm-hmm.
quite the same as being like an isolated result just because I happened to take that blood pressure today. I missed out on the one that was done last week because we were
Mm-hmm.
using two different systems. And you can't, as much as patients are super, clued up about their own care and their results, they've probably got logs of their vitals and they're writing it down, they're tracking. It's not necessarily best practice to rely on patients. They're dealing
Mm-hmm.
with multiple things at that moment, right? They're not
Right.
able to necessarily communicate with you as a provider would. So yeah, if we can keep everyone on a single system, that's one of the beautiful things for Aster, then of course we encourage that.
I love that. And I'm just thinking off the cusp here because I'm also thinking on behalf of the practitioner and the professionals. So part of the obviously the initiative for like a doula or a midwife is finding and attracting clients. And so if they are partnering with a physician who's using Aster and they want to be, part of maybe some type of referral system, then that's something that they can kind of really collaborate with the physician's office on. And then the physician can, expose these additional resources to their patients that are available to, their different partners. And they can leverage this technology to really kind of interact with each other because time is the biggest currency, right? It's like, well, we
Okay.
would be interested in these type of partnerships and we want to offer these resources for our patients, but we don't have the time to really organize all of these things in order to make this collaborative effort happen. So if there's kind of a technology that kind of makes everything very seamless and structured, then there definitely can be a partnership program put in place to make it easier for the patient and for the patient to have access to all of these different resources. Really cool. Okay.
Exactly.
I love that. Okay. So, what are the practices currently using? Like, what is the traditional EHR system, and then how can they benefit even more from switching to Aster?
Yeah, so we have a few people in the space. Many of them have been around for, 20 plus years, and we're grateful that they were around because we are still seeing providers that are using pen and paper. It's not unheard of.
Right.
So we're in a way we're lucky that these companies started when they did and were able to provide a system for providers that we serve today. But yeah, oftentimes we'll find practices using things like Athena or eClinical Works, maybe Advanced MD, very, very robust and large systems, which are often general systems. That means that they cater for multiple specialties, multiple practice types, from large hospitals down to independent providers, and they have huge scope. The
Mm-hmm.
difference is that Aster is just for women's health.
Right.
That means that when you log in, you're going to see a patient list that is broken up into the trimesters of pregnancy, that has tags, prenatal, postpartum, gyne, infants, and other, that has a prenatal flow sheet built in. So anybody that is pregnant, they will have a flow sheet automatically created for them where you can see at a glance the trends in their blood pressure, their heart rate, their symptoms, their fetal movements, and their measurements.
Mm-hmm.
So we have built a hyper specialized system for women's health providers. Means that they can see their patients, focus on those that they are kind of able to give the best care for because they're obstetrician gynecologists, because they're midwives, because they're doulas, and so on. But also, it's collaborative enough so that if you were seeing patients for other things, so you were seeing children, you do a little bit of peds here and there,
Mm-hmm.
you do a little bit of lactation and so on, you can still do that. But what you're doing is just giving yourself that extra hand because you're not digging through an legacy type system to find out specific pregnancy information, which can sometimes be quite buried. I mean, I used to use Cerner a lot of the time, and we used to have a box about this big to type in the entire note after a cesarean section.
Mm-hmm.
And that in itself,
Yeah.
I mean, it's interesting because if I want to find out data, if I want to look through what are the things that seem to happen in these cesarean sections, what are the things that maybe lead up to something not going quite well, or what were the things that we did that made it actually go really well, I would have to dig through paragraphs and paragraphs and paragraphs per patient rather than just seeing single data points of information and being able to compare those and run reports on that. So
Right.
we've kind of built it in a way in which it allows for structured data, real-time, evaluation of what's going on, and therefore you can run reports at a later date. But yeah, that's the difference. We are a super specialized EHR platform for women's health.
Yep, makes sense. And so, would a practice have to use their current EHR system in tandem, or is it replaceable completely?
Totally rip and replace right now. So if we find the right customer and they are perfectly suited to Aster, we will totally replace their current EHR. We will usually replace multiple different software tools. So with Aster, you're getting not just the EHR functionality, but you're getting billing functionality as well. You're getting eFax, which is a very, very old school,
Yeah.
type of technology, but we had to build it in. You're getting e-prescribe within our platform as well, lab ordering and results from Quest and LabCore, so you can stop logging into those too. And you're getting things like e-sign for documents and forms. We also send out patient intake and we do the scheduling. So for us, what we find is that practices can usually cut down between 3 and 5 systems and replace it with Aster. So firstly, that's a cost saving. No matter
Yes.
how you look at it, it's going to be a cost saving, but it's a huge time saving because you're not having to click through, reproduce data, make mistakes because you're typing in the address on your ePrescribe platform from the EHR. You're having
Right.
multiple tabs open, and then you're just like, what? This is taking me so long to prescribe
Mm-hmm.
one thing that it becomes a real burden and it takes away time from just seeing the next patient or spending more time with that person. Replace right now.
Yeah, that's wonderful. And one of the things I do hear from some physicians that are switching to a new EHR platform is that it is time consuming and a significant cost. So, how
Sure.
easy is it to switch platforms, and how much time is it going to take away from the practice?
Yeah, I think that's an absolutely valid question. And traditionally, again, it can take months and months and months for someone to switch these older EHR systems. Right now, though, we're in a great position. We have all of the benefits of technology at our fingertips. We have an amazing engineering team. So actually in Aster, we will do a switch within 2 to 4 weeks. And what that includes is removing the data from your current EHR system. We have these kind of automatic scripts. I won't go too much into it, but
Yeah.
essentially we can retrieve the data
Hmm.
and we can do that. A lot of the time the providers would have to sit there and click through every single case that they want to bring over, and that will take time. So we can do that, bring that into Aster. Whilst we're working on it, making sure it's correct, checking it with them, we'll do the training. And honestly, our system is super user friendly, super easy to kind of navigate through. Nothing is hidden. So we do a 2 hour training session, and then we can add an additional 1 to 2 hours after that. If we have the time, we try to do it in person.
Hmm.
So that's usually myself, CEO Fifi, and some of our other kind of team members flying out and doing the training where we can. And that's really just because we like to meet people and
Yeah, of
it's
course.
sometimes easier to be in person. But we'll do it all virtually. By 4 weeks, you know the system and you're good to go. That doesn't mean it's perfect. Of course, we try to kind of run simulations of labor and birth, for example, in areas where it can be a little bit more fast paced. We try to bring in an additional training session and have those clinicians who are often going to be using that piece tell us what would normally happen, what would you do? And then we
Hmm.
can guide them through almost a real scenario. So that is something that I think a lot of people perceive to be a challenge if you wanted to switch EHRs, but
Hmm.
today it's not. It really is not. It's just giving yourself that kind of you're giving yourself the upgraded technology, and by taking that 4 week kind of transition period, which means that it's not going to disrupt the care that you're giving, you're still going to kind of have an overlap, and then do a full switch on one day. It will really just be kind of the best investment that you could make for the practice long term.
Okay, wonderful. Okay, awesome. Yeah, it definitely seems seamless, and you already have a team that's ready to go and come in and help you convert and train. So I'm going to switch gears just a little bit and then we'll kind of go back to the vision for the future. But I really want to give aspiring entrepreneurs insight on what it takes to actually create a company like this. So I know this might be in 2024, you raised 2.4 million in pre-seed capital to support this mission. So congratulations. Walk us through just very high level what it takes to really formalize an idea like this, look for investors, present it to investors, and actually get someone to say, yes, I'm willing to support this mission.
Yeah, I think I will have to give full credit to my co-founder, Fifi Kara, who's my sister. So I mentioned that we both started the company together. We had the idea to kind of transform the way in which we receive care in women's health. And I was fortunate in that she had the background in big tech. She was leading the health team at Meta here in San Francisco. They'd flown her from London over to the Bay Area, and she had a background in entrepreneurship. So she had previously gone through a combinator, an accelerator here in the Bay Area, and had started multiple companies, honestly. So she had the experience. Now, that's not to say that we as clinicians couldn't do it, but in this type of environment, I was there for the clinical
Mm-hmm.
expertise, for the kind of domain expertise to know exactly what the problem space was and to know where our pain points are. And she was there to really take us from idea to that very first check, that first investment, and get us to the point in which we have now built a product.
Mm-hmm.
So what that like back then was that we had an idea. We done, of course, months and months of research, customer interviews, made sure that we really understood where the biggest pain points were and what we could actually solve for. And with that idea, she presented it to investors that she had previously worked with. And I think that was a great way to kind of just float the idea, see if
Mm-hmm.
anyone was it. And almost instantly we had our first check. And that was when I was, kind of taken aback because it was a very different world for me as a
Mm-hmm.
clinician from my entire professional life.
Right.
Taken aback and then decided at that point I would quit my job, move over to San Francisco, and then we, raised and closed the full round. But that was really Fifi's leadership and expertise in kind of fundraising and what that means. So I would say, just based on my experience as clinicians, we have a very particular set of skills which are super transferable to running, building a company. But maybe the things that we don't have, we can look for in other people. And in
Right.
my case, I was lucky enough that was my sister. But I would kind of suggest finding somebody who has some experience, who started a company before, who's, really plugged into the ecosystem and can help you develop those ideas.
Right. Perfect. So you have the entrepreneur, you have the clinician, and then do you have like a strong software engineer or someone who actually put the technology together? Yeah.
Absolutely. Yeah, absolutely needed, especially now using all of the latest kind of changes. The Honestly, the changes in AI that I have seen over just the last 2 years, but we're talking week to week, month to month. There's so many changes, updates, uses, things that you can build, things that you can code. I feel
Yeah.
like having a super reliable and super experienced software engineer is absolutely crucial. We have Nacho. He's our lead engineer at Aster and has been for the last 18 months to 2 years. And is always ready with the next thing. Like
Hmm.
before I've even seen it, he's ready with the next thing and is already using it, which has been amazing. I think it's really wowed some of our customers in
Hmm.
that they didn't even know they could do certain things with
Right.
with software or AI, yet here they are using it,
Right.
So yeah,
That is super awesome. So that's like the dream team right there. Love that. Okay. So let's see. It says that Aster prevents 80% of avoidable maternal health complications that cost the US over $54 billion per year. So are you guys, I know you guys are targeting B2B businesses, but what about B2G as well? Would you guys like to kind of take this in the public sector?
I mean, absolutely. Absolutely, why not is kind of the answer there.
Yeah.
I think it's a very long-term goal,
Mm-hmm.
but if we do want to make change at scale, of course, we need to partner with bigger, bolder, larger, scalable kind of areas. So whether that be in government, in policy, whether that be at huge health systems, that's the long-term vision. Absolutely. Our goal is to have all of women's health run through Aster. And
Mm-hmm.
that could be in various different ways. It may not always look like an EHR. It may be a layer on top of huge legacy EHRs like Epic and Cerner. And it may just be that we take care of that
Mm-hmm.
women's health side of things.
Right.
So for us, yeah, the long-term goal is scale. There are 4 million births still happening in the US. And we don't just do birth, we do all of women's health across the board, from preconception to from puberty all the way to menopause and beyond, and even gyn cancers. So for us, it's just a case of getting our foot in the door and growing as much as we can so that we can impact as many people as possible. And in terms of preventable pregnancy complications, preventable means things that you just could not avoid. These are the non-emergencies, the non kind of time sensitive issues. So these are things like your preeclampsias, your emergency C-sections, your gestational diabetes, things like hypertension in pregnancy, and all of the things that you can prevent if you're able to detect and spot those issues earlier and also treat earlier.
Mm-hmm.
So with our technology, big goal, obviously, but it's something to work towards. If you can spot trends in blood pressure, if you're able to have people track their health at home and then submit information directly into the EHR, which we can then run reports on, these are the ways in which we feel like we can really make a difference and move the needle.
Yes. And this is wonderful. So thank you for kind of really taking us down this journey. And I definitely see the impact that Aster is having in women's healthcare. And just having a system like this that, really handles all of the different ecosystems, all the different practitioners, bringing everybody together and making the process seamless for practitioners is vital, just to really kind of win back their time and really focus on what it is they're there to do, which is take care of their patients.
Yeah.
But the one thing that sticks out to me that kind of keeps ringing in my head is kind of going back to your original story in allowing the women and especially Black women to feel seen and heard. What can we do to really commit to this mission? Or more importantly, let's tie Aster's technology to how this can become more prevalent.
Yeah. I think one of the things is being aware of the solutions that exist. And it's not just technology, this can be simple advocacy, right? Being aware that you can speak up, being aware that there are hospitals and providers out there that do support you as a Black woman who is pregnant. We see a lot of that even here in San Francisco at UCSF, for example, there's a Black wellness clinic. There are multiple solutions as long as we know that they exist. We can
Mm-hmm.
use them and we can make sure that we're safer. Now, that is your day to day, something that everybody could do, whether you're pregnant, whether you're a woman, whatever the case,
Right.
you could know what the solutions are and you can be there to help advocate and bring us closer to that goal. If you're using technology or you're aware of technology like Aster, telling your OBGYN, telling your midwife, letting your lactation consultant know if they didn't already know that there are tools out there that can help them deliver their very best care and give them some of their life back, honestly, which is one of the reasons that we're not seeing as much of the workforce development that we would expect in areas like women's health.
Right.
And then if you're in something like investment, you know what to do.
Yeah.
Get us some
Yeah.
more investment, spread the word around women's health companies. It's not a niche market. It is absolutely not a niche market. It's a
Mm-hmm.
huge growing market. And, women are the decision makers when it comes to health for the entire family. If they have the right tools and the right information, they will make us, they will take us to the next level. So, yeah, don't be afraid to just shout from the rooftops about companies that are out there, solutions that already exist, creating your own ideas,
Mm-hmm.
supporting and looking after your own family as well as others is kind of the biggest thing that you can do right now. And then helping with policy and legislation. So when it comes to supporting things like the Momnibus bill, do that because it has 12 different points of areas which could improve maternal health. A very simple way that you can get involved without necessarily doing anything physical or mentally challenging.
Mm-hmm.
But yeah, anyone in any sector, in any walk of life can make a difference to this particular challenge. And
Yeah.
yeah, we're just here doing our bit.
Absolutely. And this all ties back to really empowering the provider in order for them to
Yes.
give the care that they need to, right? And really serving them for them to make this happen, right? And I don't know how much relevance I mean, it's relevant, but I don't know. I'm going to talk about it just because it's in the top of my head. But so I'm working with an OBGYN. So she's one of my clients and she's moving to a new hospital. So she's going to
Okay.
relocate for a better environment. One of the things that most physicians and providers, complain about, and also what takes up their time, not only in the office, but outside office hours as well, is charting. And
Yes.
you would be surprised how many practices and, in hospitals, even in cities, are so behind in these type of systems and are still going the traditional route, which is really
Yeah.
burning out their physicians amongst other things. And so one of the things that really stood out for her was very simple is she chose to leave the practice. Not only it was a toxic environment, but one of the things that stood out to her in her new practice is the systems that they were using. So her
Okay.
ability to be able to chart better is just very simple, but her
Yeah.
ability just to be able to chart better, not have to take her work home and finish it in the office, even if it's after patients, not being able to having to take it home made her decide to uproot her entire life for a better quality of life so that she can better take care of her patients and then ultimately herself, right? So
Okay.
I'm just putting that out there for anyone who is considering like really evolving their systems, and especially with something like Aster, is,
Yeah.
some of those simple components, because I know we can get even more technical if we wanted to, but some of those simple systems that is really going to save time, energy, money, those are things that are really important, not only for the practice from the revenue perspective, but also for the physicians who are actually taking care of the patient. So I'm just that stood out to me. So I wanted to share
Thank
that.
you. I'm glad you said it because that's exactly what we're trying to do.
Yeah.
Exactly.
Awesome. So, Dr. Layla, tell us what keeps you up at night?
Well, that's a great question. I think, we don't often hear a lot about what happens kind of behind the scenes.
Yeah.
I do have two young kids. I have a 5-year-old, my son Ethan, and I have a 2-year-old. So really, it's just them. It's just the energy that we use day to day with them. I think, like company wise, the founder journey is very up and down. We don't necessarily have the direct patient contact that I used to have back when I was, working in the clinical setting. But what we do have now is a bit of a different kind of experience of making sure our providers do have all the tools that they need, making sure that we're listening to their feedback all of the time, of course, making sure that we don't have any issues in the system. So it's a little bit different. I would say that every single day we continue to grow, and I don't think it's
Mhm.
ever going to stop, which is
Right.
just interesting and in itself. And there's always something that we can do, that we can add, that we can change, that we can improve. And so it's a constant debate, honestly, within the team, and it's a constant kind of brainstorming session. Every
Hmm.
day there's a new idea and a new solution, and sometimes there's a new pain point that providers are finding that's happening during their work because of other things outside of our control.
Hmm.
Even recently, changes to Medicaid has meant that some of our providers are having to figure out things differently that they wouldn't normally have to worry about,
Hmm.
how we can support them. So there's a lot that we can do and that we think about day to day, even on this side of the work.
Right, for sure. And I'm glad that you brought that up. So, another type of client that I work with is, for example, another OBGYN who wants to transition into a complete wellness practice. So, not stop
Yeah.
taking insurance completely. So, can Aster come into play in really, empowering independent physicians as well?
100%. We have quite a few actually on our platform that have either started their own practices that have a blend of gyne and wellness, or that is what they call direct care. So they don't take insurance at all and it's purely cash pay. We support that too. So in Aster, when it comes to helping with payments and billing, we do have coding features, we do have claim submission, but we
Hmm.
also have things like Superbill Generator. And we can allow you to send your patients invoices and they can pay you in our system. So for us, we support all types of kind of practice groups,
Hmm.
but also at the same time, we're women's health specific, but that extends, like I said, to the full ecosystem of care. So it could be wellness, it could be therapy, it could be sleep, it could be nutrition, lactation, postpartum only. We have some providers that just do that. So yeah, absolutely take a look at kind of our software, take a look at others and see what really suits you. But yeah, we would be a great fit.
Absolutely. And so, what about the OBGYNs that have separate like telehealth or health coaching and consulting practices that focus on perimenopausal treatments and solutions like that? Do you have different tiers of your system to make it digestible for a new entrepreneur?
I would say yes. I think ours is based, we try to do an all-in-one cost. We try to make it super simple. One of the
Yeah.
things I find difficult is adding on
Yeah.
like five different things and not understanding, well, how much is this going to cost? So we try to wrap it into bundles. For us, we have tiers ranging from right now $150 a month to $250 a month. But that will be inclusive of a bundle of features depending on what you need. Some people might want to start out without the EFACs and labs, but they might want to
Yeah.
start out on a basic tier, or they might want to start out without e-prescribe because they have to stay within their contract for another 6 months with that thing that they're using. So
Hmm.
yeah, we make it simple. We just wrap everything together in packages as we can, and that price is for that provider. But with Aster, which is quite nice, admin team members, support staff actually will have that login for free because the provider is obviously paying the cost. We
Mm-hmm.
don't go by logins. We don't go by. We try to keep it simple because honestly, it's more difficult when you're adding up so many different
Yeah,
things
for
and you
sure.
don't
Yeah,
really
I
know
understand.
what's going. So yeah.
Okay, interesting. Yeah, I'm gonna recommend that because I have OBGYNs that work with the group or are working with the
Oh,
hospital who actually want to start their own coaching, consulting, or they're doing functional health on the side, and they do need a really inclusive EHR system specifically for women's health. So this would be a fantastic idea, and it's definitely reasonable. All right, perfect. Well, tell everybody where we can find you, where anybody interested in learning more can find out, and we'll
yeah.
go from there. Go ahead.
Yeah, I mean, absolutely. Just check us out over social media. So we're at AsterCare underscore on Instagram, for example. It's ASTER care. And our website is the same, astercare.com. Myself and my co-founder Fifi are active on LinkedIn. She's Fifi Kara with a K. Super easy to find.
Hmm.
And then also, we love seeing people in person. So if there are physicians out there that want to take a look at Aster, if there are events out there around maternal health or women's health, and you want, to learn a little bit more about what we're doing with AI in healthcare, we love to be there. So yeah, would love to catch up with any of your subscribers and your listeners for sure.
Yes, that's fantastic. All right, perfect. Well, thank you, Dr. Layla. It's been a
Thank
wonderful hearing about your journey and then the difference you're making in women's health. This is absolutely fantastic. And I love that you were able to kind of share a little bit behind the scenes, and hopefully we can dive a little bit more deeper in another conversation. But thank you guys so much for listening in this week. This is Recalibrated Vision. I'm Bianca Ariel, and I want you guys to always and remember to stay free. See you next time.
thank you.
Bye.